How did the Goondiwindi model change the mindset of staff to adopt or change their practices? Who drove the processes and what elements made the difference?
So we had the fortunate coincidence of already being at a crossroads in our unit where the unit was critically endangered by lack of general midwives, general nurses with a midwifery skill set to cover a 24-hour roster. And we had the political will for the maternity service not to die because the Cheryl Hurst report was just out and the political climate was finally turning against the closure of rural birth units. We had a group of doctors and a group of midwives who already respected each other and had good communication, and there wasn't much us and them. And we had a director of nursing who was keen to oversee the change process, and we had management above her who agreed to support us just one step of the way each time to see what happened. So we applied for funding to scope all models. We just said, let's throw the baby out with the bathwater and see what we get. Don't assume anything. Any idea is welcome. And spent 12 months doing a scoping project about, okay, this isn't working, what else might? And we came up with something close to what we've finally adopted at the end of that process. No one wanted to see the maternity service close, and so that gave people the opportunity to open their minds up a bit to the possibility of doing business differently. And then we were able to get the go-ahead to implement the model and to provide our first month's data and review that and to continue. But it's a work in progress. It's certainly not a finished model where everything's perfect, and there's challenges along the way, the brunt of most of which has fallen, I think, on our Director of Nursing, who has had to oversee change where staff who were salaried employees became, who worked shifts, became, their income was annualised and they were salaried, and a caseload was allocated, and the caseload that was decided on was a little bit of, there was nothing else to copy in the state of Queensland. So we looked at similar things happening in metropolitan centres, and I still think we probably haven't got that quite right. I think in a rural area with increased complexity due to social issues, distance to care, we probably should not be aiming for a caseload midwife to be delivering 40 women per year if it's to be sustainable. So that's the next challenge for us. That's the thing we're working on now.
Okay, thank you. How can consumers help change the culture of midwifery services? How can resistance to change be overcome?
I think consumers are critically important in this process, and that we need to not just hope that they put their hands up to be heard, we need to be actively engaging them and involving them in the change process in any health service. And that was a culture change for us as well. We haven't always done that very well, but we're very mindful of that now, and we try to invite consumer representation onto any committee, management group, decision-making panel we have, and we try to use mechanisms to seek community input. I think consumers are very powerful, and lots of them write letters directly to the Minister if they feel they're not being heard.
Terrific, thank you. What is the ratio of staff required to sufficiently and safely run the caseload model at Goondiwindi, i.e. how many FTE for work-life balance?
There's two parts to that answer. The first one is that you need to look at how many women you're delivering and try to arrive, and it's a little bit of trial and error and experience over time, at a number which represents what we think a full-time caseload midwife should be able to handle for work-life balance. And then that's the number of FTEs you need to aim to be funded for. And again, on top of that, work-life balance still cannot be achieved if you just have full-time caseload midwives with a caseload of, say, 35, because the cover still doesn't work, there aren't enough bums on seats, and so you need to look at, is 0.8 the perfect employment opportunity for a caseload midwife? Is it 0.6? Is it 0.7? And it'll be different for different people. It's different for a part-time mother from what it is for someone who's early in their career, gung-ho, wants to work full-time, but maybe still should be encouraged to look at 0.8 for work-life balance. I would like to ask Katie Jefford, our Director of Nursing, if she has anything else to add to that. She's, I think, far more involved in the process of trying to work out what the perfect caseload for Goondiwindi Health Service is.
Can I give her the
Just
microphone?
in the middle there.
Thank you.
While Katie's getting organised, I'll also just say that what works at Gundawindi won't work at every other service. So whilst Gundawindi might have a sort of a view around what's perfect for caseload, you know, it's the same as we discussed before, that you've got to look at your own local area as well.
No. No. Let me give you this one. Thank you.
Sue, I think you did that very well. I think you answered that question extremely well. I think what we've learnt over the time in Gundawindi over the last 4 years is we did start with a funding of a caseload of 40. That has crept up to 43. We've got a fatigued group of midwives at the moment. We're in negotiations with the district and with QNU looking at a caseload of around 32 to 35. I think the difference in Gundawindi is our caseload model is our only model. We don't have a core group of midwives to hand over to, which you do have in the larger metropolitan areas. You know, the woman goes to Caesar, you know, after 4 or 5 hours, the midwife goes home. There's another midwife there on shift to take over that care. We don't have that opportunity. So in a rural area where you don't have another model to back you up, you need to really start looking at a reduced caseload. And with regards to the part-time hours, I think we've found our full-time staff are getting quite fatigued after a couple of years, aren't having a great work-life balance. And I think from an ideal point of view, around about 0.6 to 0.7 is probably an ideal FTE to be working. And I suppose we're covering a service 7 days a week. So if we've got a head count of 7, that means there's one person on call 1 night a week. And that seems to be quite sustainable. It's when you've got midwives on call 3 or 4 nights a week that they start getting extremely fatigued, especially if for some strange reason they have 3 deliveries that week, a couple of caesarean sections, transfer out. So that's when the work-life balance really starts to take its toll and not occur. And that's where midwives then become really disconcerted with their practice and it's really fatigue that sets in. So I think, you know, did you want to say something, Roxana? Oh. Yes, Liz.
Sorry. The other thing that has to be sort of factored into that is, again, the way that people work. So if you're on call for the entire practice for a night, and that's 7 midwives or 6 midwives, and one night can be like hell on wheels. If you're on call for just you and a partner with a smaller number of women, 3 nights can be okay, or 5 nights can be okay. So I just want to give the understanding that the way of establishing the caseload actually, and the way that people work there on call, will significantly vary from service to service. And I think we need to be realistic about that wherever it is, whether it's rural or metro or whatever.
And I think you're right, because that's about knowing your own service, knowing your workforce capability, knowing what, you know, people want, how the midwives want to work. You can't force a midwife to work in a model that she doesn't want to work in. So it's really about doing some really good implementation studies with your own community and working out what your community wants. And your community does include your GPs and your midwives, as long as your patients.
Thank you. Can I have that back? Thanks. Thank you. What are the barriers in training local GPs to have necessary skills?
You need to have enough, I'm assuming by that you mean GP obstetricians, to have the necessary skills. And I think it's very important that we support opportunities for people to go away, to maintain skills, do special courses. Sometimes we've been able to attract a course to come to us. We've held the Macram course in Gundawindi in the past, for example. So I think that's about funding, backfilling, arranging for cover, rostering to make it happen. But there's plenty of opportunities out there for skills maintenance. It's just a matter of planning to take them up.
Okay, thank you. What things worried the Gundawindi doctors before the model started?
Well, as I said, it was a perfect storm. What worried us most was that the service would close. And that might sound illogical, but even from a purely selfish perspective, the service did close for a brief period of time. And did women stop turning up in Gundawindi in labour? No. And were we maintaining skills and ready for the emergencies because we were balancing that against a diet of planned obstetric care? No. So that was a far worse situation for us. And we were of a mind to accept change and make something else work.
Thank you. Is VBAC and breach cause to exclude women from the Goondiwindi service?
That's a broader question about risk stratification, and I think in order to work responsibly and provide good outcomes, risk stratification is critical. And in our service at the moment, we've made decisions around our service capability that we are not able yet to support VBAC, but we're moving towards that. And breech delivery, I think in a planned sense, and I think most of the obstetricians we consult with would agree, you've got to be skilled to catch the unexpected undiagnosed breech, and it's happened to us twice in the last couple of years, and it all worked out fine. But I think if you know there's a breech and you have a woman whose choice is for vaginal breech birth, then it's logical to plan that in a service where there is regular experience with that, and that's what we try to do.
Okay, thank you. This next one, I may need the person who wrote this because I'll give it my best shot. WRT medical staff do non-dip obs, don GCCA. Is that person in the room? That's better. Thanks, Sue.
With respect to medical staff, do non-DIPOBs, non-JCCA participate in maternity service? The suite of macrum, also neonatal resus, CTG, intrapartum fetal surveillance can work well. Do you use this? Yes, we do. We use all of the above. And in fact, as I alluded to, we went through a process of scoping, model implementation, and now we're running a model and it's evolving as we go. Model implementation involved a period of concerted upskilling for midwives who were used to working shifts to become caseload midwives, and all of them went away and worked for periods of time in large units with large birth numbers. They did courses, we had courses come to us, they were financially supported through that project, through that process by funding, which was earmarked specifically to make that happen. And we engage in similar activities as a unit in an ongoing sense. With respect to medical staff, non-DIPOBs participating in maternity service, we are very, very keen to make sure that that happens. So in our model, the patient's usual GP is deliberately included in the process. We encourage them to see their own GP throughout the antenatal period, as well as engaging in the visits with their midwife. And I think that's important because, to me, the GP is the whole-of-life care partner, primary health care manager. They've known the patient before they were pregnant. They'll know the patient in 6 months' time when the child's very sick and the maternity service is no longer involved. We actually have at our hospital a roster where there's an SMO who's at the hospital and they're the main hospital doctor for the day for 10 hours, and then there's proximate call done by that doctor overnight. We actively engage those SMOs who do not hold obstetric credentialing to participate in maternity education in our service. And that person is the person our midwife contacts initially when a patient is in labour in the health service. I don't want the SMO, who's the go-to person for the day in my health service, to be unaware that there is a woman giving birth, because they may well be the person grabbed by the scruff of the neck and run to labour ward with me. I've called Sue, but she's 5 minutes away. Available, Johnny on the spot. And I think it's really important that we don't put maternity care in a silo that makes other doctors feel it's some special category that they can't participate in. It really worries me that credentialing, while helping safety, is creating silos within medicine, and that the obstetric part is just something that only special people with a special ticket do.
Terrific, thank you. That's the last question for you. Give her a round of applause. Thank you, Sue. Are you mic'd up, Liz? Because the next questions are for you. Caseload models have been repeatedly put forward. Can I have that?
I am mic'd up. Is that enough?
Yep, that's fine, thanks.
Great.
Caseload models have been repeatedly put forward. Many midwives do not want to work in a caseload model. Where will sufficient caseload midwives come from?
I think that that sort of has got two parts to it. The first one, I know that there is a view that midwives don't want to work in caseload models. I would refute that view to some degree, because recent evidence from my perspective is that we put out an expression of interest on Facebook just 3 weeks ago. We've had 160 midwives contact us wanting to work caseload in our model. So I understand that in rural areas you're drawing from your local workforce and that there may be concerns from midwives in rural areas about working in a caseload model, but I think that good education around what that actually means for midwives is the key, and that the things that Katie and I were referring to around being on call and what that can look like are sort of the key element to making midwives understand that it is sustainable and that there is an ability to have flexibility and a work-life balance. And it's about working out the way that you work, if that makes sense. And it's one of the really key elements. The other thing is obviously to look at our midwifery education and the fact that we've now got large cohorts of Bachelor of Midwifery students coming through, and those midwives are the midwives of the future, and they're being educated to provide continuity of midwifery care. So whilst I understand that the transition may be a little bit challenging for the next few years, we certainly are developing a workforce of continuity of care midwives to take up roles in caseload.
Okay, thank you. Is it easy for rural midwives to become eligible, and why aren't more becoming eligible?
Yeah, well, it's the same for rural midwives really, I suppose, as metropolitan midwives in some respects, as long as they've got access to birthing services. So if you've been working across the scope of practice of a midwife in the way that you've provided clinical care for within the last sort of 5 years, then it's straightforward. You complete MPR, and whilst when I say straightforward, those of us that are eligible will know that straightforward sort of has straightforward with a bureaucratic tinge to it, like it takes time, you've got to send things in, but in terms of the on the ground, what you actually have to complete and what you have to do, it's a very straightforward process, similar to just becoming registered really. It's just sort of taking that to a slightly higher level. The reason I think that most midwives are not, or that there's not a lot of people taking up eligibility, is I suppose the position on the other side, that health services aren't really actively using eligible midwives, and so the motivation for becoming eligible and jumping through those hoops and working in that way is not there, because you if you jump through those hoops and then you're faced with, well, I'm still working in the health service doing exactly the same thing and nothing has changed, then what's the motivation to actually get eligible and start working? I think once hospitals and health services start to recognise the benefits of using eligible midwives and sort of engaging more in that space, that there'll certainly be more rural midwives, and that health services will be actually actively encouraging the midwives that are able to gain eligibility.
Okay, thank you. And the last question for you, Liz. Very thought-provoking, clear. What is the role of the Health Minister in overcoming barriers to private practice eligible midwives in other health services throughout Queensland?
Probably the Health Minister should have answered that question. The role of the Health Minister has really fulfilled his role, I guess. The role of the Health Minister is to do what he's done, and that is to write to the chairs of the boards of the HHSs and indicate to them that the government does support access for eligible midwives across Queensland, and that the rollout of these models, he's both given me his undertaking at an individual level at meetings, and he's obviously stated that publicly on the record that he's extremely supportive of that model. So I think he's made his views very, very clear. I think really it's now down to the next level, and it's up to the HHSs and the CEOs of the HHSs and the boards to start making that a reality.
Okay, thank you. Could you please thank Liz Wilkes? Thanks, Liz. John, you're next. Are you mic'd up?
Is that working? Yeah, cool.
Yep, okay. Do Queensland Health accept the data presented by Dr Hall, by yourself, that it is statistically safer?
I guess in essence that's a question for Queensland Health. That data was sourced from the Queensland Perinatal Data Collection and collated, and that's done every year annually through the Rural Doctors Association of Queensland, who presented at our conference, specifically with a focus on rural. the data is what it is. That's the perinatal data in Queensland. I don't know how you could mince that or churn it in such a way that it would look better or different, but if people want to challenge that and have a look at how we source that, I'm happy to talk to that or go into more detail. Clearly in 5 minutes I couldn't show you how that was calculated, but happy to talk to people off in the breaks about that.
Okay, thank you. John, great talk, great commitment. Medical cultural barriers to change are significant. How do we address change and overcome this?
Come to meetings like this and lobby the government for about 30 years, not me, but my colleagues, my rural doctor colleagues, and some of them are in the room here who have been banging on about this for many years before I got onto the scene. People like Dan Manahan, Dennis Lennox, and there's been numerous guys, Bruce Chater, Col Owen. People have been banging on about this for seriously 30 years. Col Owen, I've spoken to him about this. This is how we break this down and change it, and it's about pushing politically in the right direction and then collaborating with the right stakeholders and getting around the table and sorting it out. It's about identifying community needs and making sure that we don't let our community down and doing the best we can to work together to make that happen.
Okay, thank you. What do you mean by collaboration? Medically focused birthing or...
I get where that question's going.
Yep.
I read it before.
Okay.
Look, we mean, when we say collaboration, we really, really mean it in the country. For us, working in rural maternity units, it makes our life a lot easier to have a good team of midwives and nurses around us and other hospital workers, and that seriously makes our day-to-day life easier. We seriously do mean collaboration. When we say collaboration, we mean working closely with people. We mean giving away some of the tasks that we might have done previously to people that can do it if we know that they're competent to do it. That's exactly what it means. And, for instance, I've worked in a lot of rural maternity units. I worked in Stanthorpe for 5 years and I've done locums in many hospitals around Queensland. And a lot of the time when they've called me because they're vulnerable and they needed people to fill holes where they were going to close the service, I don't like doing locums. But in all of those environments, I've witnessed situations where midwives want you there for every birth, and it's motivated by them. So I'm more than happy as a doctor to not be there if they're happy to manage a normal birth. And this is what we mean by collaboration. If we can build systems around midwives that support them, that allow them to do that more independently, that's a win-win for doctors. This is not just political speak. This is real nuts and bolts on the ground. Collaborate, make it better for the women, make it better for the workers so that it's more sustainable and it's a win-win.
Okay, terrific, thank you. And the last question for you is along those lines as well. It's for Sue, Masel and John. Talk about collaboration with specialists. What are the issues?
Do you want to talk to that? Because I've got something to say.
And you go next.
We collaborate very closely with our specialist colleagues and we need them. They're essential. We use the specialists through the flying obstetrician and gynaecology service, and probably more importantly, we use our specialist colleagues who are in our main referral centre. One of the ways that I try and collaborate is by doing upskilling in our local referral centre, so that normally is 1 to 2 weeks a year where we go back to the referral centre and build relationships and work hand in hand next to our specialist colleagues. But by far and away, that is with direct relationships with those specialists. I think sometimes these relationships break down due to the nature of the care that happens in big centres and the rotation of junior staff and registrars. And where I've seen that collaboration break down is miscommunication at that level with the junior staff, and I think it works much better when there's direct consultant to GP obstetrician communication, and that's something that we've worked on locally and I think is improving. But I think any perception of non-collaboration or us not working together, we're all on the same page. We want what's best for our patients, and sometimes our opinions differ on what should happen with a lady, but you can rest assured if you're talking to me, I'm really concerned about what's best for that lady and her baby, and sometimes our views are not always eye to eye on that.
Okay, thank you, Sue.
And I wholeheartedly endorse what John said about that. It's been my experience that, and you can tell from what I've said already today, I'm very keen to take up opportunities to encourage participation and education of all doctors in maternity care. And that makes me a little bit loath to skip the registrar and call the consultant direct. But it has been my experience that the registrars they're in an environment where they're learning lots of new things, they're trying to work out how a big unit works, they're navigating their way through that. They can't be expected to understand what services and what staff are on the ground in all these little country towns around Queensland. So sometimes you have to speak GP obstetrician to consultant, you have to name it and claim it. If you know that you're following the service capability framework and you're sending a woman up who gets bounced back having been seen by a junior registrar without even the question you sent her 250 kilometres for being answered, well, you've got to do something about that. So there are issues, but I don't feel that we're unsupported in a clinical governance sense by the consultants in the units we deal with. It's organisational and procedural where we have to navigate, and we need bureaucratic support around that. And I think that Toowoomba is improving that all the time.
Okay, thank you. And John, somebody in the break asked me to ask you the same question that was asked of the Minister. They felt that you were better placed to answer this question. So it's been asked before. No LSCS availability. How are you going to manage the geographical distances and still reach the Cat 1, 2 and 3 Caesar time frames?
I just spent 5 days working for Bruce Chater in Theodore under a model where this is actually happening, and thought about that a lot. Basically, what Bruce is doing at the moment, because his theatre is not functional, is for most women, they birth locally. For the women that need to be transferred intrapartum, they go in the back of an ambulance with a midwife, and he follows in his car behind to Billawheeler, and he personally does the Caesar and takes responsibility for that case. That is the model, and under the current service capability framework, it allows for that to happen within 75 minutes, I think. So, that's the practicalities of how that would happen. With respect to timeframes for a Cat 1 Caesar, which is a stat Caesar, clearly that's not going to be met under that model. But I would say to you and people in the room that in my experience, a true Category 1 Caesar in a rural unit that's appropriately risk stratifying is a rare thing. In my 5 years working in Stanthorpe, I think I did one that would be categorised as a true stat Caesar. And I think this is what the statistics bear out, is that's a fear that we're going to not be able to deal with this stuff. But actually, if we look at the numbers and we're doing it appropriately and we have the right risk stratification and referral processes and communication with our specialist colleagues, we can avoid those situations. We're never going to avoid them completely, and deaths are going to occur in the bush as much as they happen in Royal North Shore Hospital in Sydney. But this is my other bugbear in this space, is pathology happens, bad outcomes happen wherever we are, and when they happen in the bush, people say it's not safe because of your geography. If that same death had happened in Royal North Shore, which it would have, because it's the pathology that killed the baby, not the process, people wouldn't have blinked. So this is, I think this is the problem.
And on that note, thank you very much, John. Can you give him a round of applause? Thank you. And Professor Kildea?
Sue, please.
Sue?
Yes.
Without management, will nothing seems to change. How can we get management willing to change?
Oh, the easy questions. That's a tricky one because it's kind of management, like what is management? I think change, there's a couple of components to change. There's books written on this, isn't there? But I think it'll often come from the top. And it's if you've got that leadership at the top and the collaboration at the top and the willingness for change at the top, then it'll filter down. And you've got a zero tolerance for it not happening. So I think if you've got it right at the very top, if the leaders are saying this is how we want it done, we've now got the minister saying that, so that's fantastic to have such incredible leadership from the minister and such really clear message he's given to all of us. So if that can filter down, and I think it should, then I think that's where it happens. So from the top, this is going to happen, make it happen, people will make it happen.
And I think the next question goes into that. How do we ensure you create local, unprecedented leadership?
It's a beautiful quote, isn't it? Look, I think there's a little bit of leadership in all of us, and sometimes it just needs to sort of be given a bit of water and grow. But it doesn't have, the leadership doesn't necessarily have to come from the top. I think having the leaders on board is really important. But I think that leaders are from many, many places, and they might be from the consumers. We've got incredible consumers at the Mater that are actually leading change in our organisation because of the way they operate with our organisation. So the leadership can come from anywhere. It can come from the students. It can come from anywhere. So creating it and growing it, often it's actually enabling it to flower, isn't it? And helping and assisting that way. I don't know if I answered that question.
Okay. Yeah, well, let's see how
Good
we go
enough.
with the others. Excellent presentation, thank you. Some directors and midwives say that the nurse midwives do not want to be on call with caseload models. What advice would you give them to assist in service redesign?
Yeah, look, this is the one that comes up quite a lot. I think when we don't get the model right, there's a lot more call involved. So we've just looked at that in part of the Mango study, and we've actually documented the number of phone calls, we've documented the number of text messages, we've documented everything that has come in, every contact between the woman and the primary or any of the midwives, and it's actually incredible. The call, it's nearly all happens between 7 a.m. and 4 o'clock in the afternoon. Hardly any of it's happening after hours, and when it is happening after hours, it's nearly always when they're on call. Almost none is in the middle of the night unless it's birthing. So I think it goes back to what Liz said. There's a miscommunication. There's a story out there that there's huge amounts of call that will happen when we don't get the model right. So when it's not staffed right, when we don't get backfill when we need it, then you'll see a lot more call and you'll get tired, haggard midwives. But not when the model's right.
Okay.
So it's communicating that. And part of that is actually getting our students into the model. I think in many places the students don't get into the model, and in many places the medical students have no exposure to the models at all. And I think that's a really big problem, because our junior doctors and registrars, as they're coming through, if they're not working with the midwives in that model, how are they going to learn to work to build that respect and those relationships? I think we've changed midwifery quite significantly in some places. We haven't changed the medical training to go side by side with that as well as we could have.
Okay. Now, I'm aware there's some hands going up for people wanting to speak. We'll give you that opportunity at the end. Sue, I'm actually going to give you this question because, as you'll see.
Oh, if I had my glasses. Can you read that? It's going back to the slide that looked at the the babies that were born before arrival and asking where did those births occur. We're currently mapping that. I was hoping to have that for today, but we're trying to map that at the moment. So I can't answer that just yet, sorry.
Okay, terrific, thank you. Return to birthing country has been on the agenda for some time, with United true commitment to doing business differently. What do you see as the next step, and is there a plan to put this into action?
Well, I'm pleased to say I think the planets might finally be aligning for this one after sort of 20, 30 years. The National Maternity Plan has got a key targets in there for seeing a trial of birthing on country. There's been a literature review that's looked at all the evidence to date, and from that there was a national workshop in Alice Springs this year which brought all the stakeholders together. The report from that is almost finalised, and what that's going to be saying is they're going to be asking the maternity services interjurisdictional committee to work side by side with NACHO, the Aboriginal Community, National Aboriginal Community Controlled Health Organisation, peak body, to identify sites, and then once the sites can move forward, the framework for what birthing on country model might look like is currently being developed. So what the service characteristics are, how to make it safe, what the training and education, all of that is currently being developed. So it's close. The only problem at the moment is that it's a trial with no money, I think. So that's a little sticking point that needs to be found.
Okay, thank you. This is a question for both you and John. What is the evidence of safety in rural birthing in terms of gynecological outcomes for women? Is there any evidence at all?
I don't know if this is Hello. I don't know of any, but what I was going to say is that I've been involved with the VLAD process in Queensland Health, and which people may or may not know means variable life adjusted displays, and it's a way of tracking outcomes across gynecology in birthing, and it specifically looks at things like perineal tears and episiotomies and outcomes in that regard. So I know it's being monitored, and I can say quite confidently that that the rural units are doing quite well in that space. I can't give you statistics, but from my exposure to that, anecdotally, the rural units are doing quite well in that space. Michael Humphreys may be able to comment further on that, but that's my understanding.
Does he want to? Okay, let's give him a microphone.
He probably asked the question.
No, he didn't.
No, I didn't ask the question. You will be aware, John, that I'm actually not allowed to talk specifically about what I see as part of the VLAD subcommittee review group, but I don't think I've seen any rural maternity services come up with level 3 flags in a year. And overall, I think just as a comment is that the responses from maternity services that are flagging have actually improved over the last year or so. So they're starting to take quality assurance quite seriously. I don't think I can say anything else because it's meant to be a confidential committee.
Okay, thank you. And the last one I'll actually pass back to you, Sue. It's about the hub and spoke model. Have you got your glasses?
Yes. Makes it so much easier.
It does.
Glasses. Hub and spoke model, feedback from managers in rural areas that have not supported because of the inability to utilise midwives in all other clinical areas. Key point, cultural change at local levels is needed. I think I'm understanding that to say that...
Is the person, the owner of this question, do you want to clarify it, as it's the last question for the panel?
Is it saying that that the managers in rural areas are not supporting the change? Is that what it's saying? I'm not sure if that's what it's saying. I think some of the managers in rural areas should be encouraged to come to forums like this. I think this is just a stunning forum. If Queensland Centre for Mothers and Babies can do this again in other areas, and if managers come along, if you're committed to evidence-based practice, if you're committed to women-centred care, which I would like to think that all managers would be, then you'd have to ask why not? Why wouldn't you try it?
Okay, terrific, thank you. And I've got a last question before I open up the forum, just for if there's any burning questions before we start tapping into the expertise within this room. And this is to whoever wants to answer it on the panel. It's a general question. Not all midwives wish to be involved in independent practice and caseload management. Why do midwives who work in small rural obstetric units where wonderful services are provided to our mothers and families need to dramatically change our service mode and delivery?
The answer is they don't.
That's what I said.
There is no one-size-fits-all model that's going to work everywhere in Queensland. And even within a model like ours, which has become fully caseload, one of the ways of change managing not enough staff for work-life balance is to have some short-term contracts where we give rostered hours to registered midwives who are able to help provide postnatal care or some of the things in the service that can free up some of the caseload midwives from those things and help us return to work-life balance. So that's one example of a blend in a situation which is, for all intents and purposes, 100% caseload. I think we've just got to use our imaginations and find ways to engage any midwife out there who wants to be working in rural Queensland.
Can I also... Oh, sorry, Sue. Because what I was going to say is that I think the point that Katie made before about the fact that the whole service has changed to caseload is one of the answers in that the whole service doesn't have to become caseload. You know, you can have, as Sue's saying, a blend of people that are working at a core level and people that are working in caseload. But I guess the questions that we're sort of asking here at the moment are the fact that access has decreased in some areas and there's a finite, funding pool. We're talking about services that are unable to continue functioning or have closed for some reason. So we're not necessarily talking about services that are running beautifully and that everything's on target.
Yeah, I'd probably just add to that when you look at the workforce projections and you look at the new students that are coming through, a lot of them want to work in caseload. So I think if you've got services that are humming along quite nicely and everyone's happy, why would you change it? But it's what's, I think, is coming in the future when you look at what's happening out there. So to keep rural services open, I don't think we can go back to how it was before. I think we do have to be more innovative because of the workforce issues and the very reasons that they closed.
I think there's ways of doing that where we keep the models that are functioning going. I'm very cautious that we don't use language around things like best practice models that we then foist upon people that could actually see rural units close if people don't agree with those models. So, looking at best practice and then saying if your model doesn't fit that, then all of a sudden that's sort of not an acceptable model anymore. I think that could be a real tragedy and we could see units close because of it. But what could happen in this space is towns like Dalby, where you've got a really good model that's functioning with full-time doctors in the hospital, you've got VMOs visiting in the town that support that and a good bunch of midwives that work really well together. You could have eligible midwives sitting in the private practice with the VMOs, increase your midwifery workforce, decrease the amount of call the public guys have to do, support if they're upskilling and the midwives actually have an expanded scope of practice across both those models. You could have less need to call in the doctors when they are. So then you're putting less back pressure onto the medical people. So you could actually augment existing models and make them stronger, but I would be very cautious about any models being foisted upon people, especially when they're currently working, and that's certainly not what we're about.
And I think some of the big messages this morning is there's not one size that fits all, it's a blend and it's about what will work in the individual area. Could you please thank Sue Kildea? Thank you. We might spend who's got the microphone? Oh, thank you. We might spend a few minutes. I noticed that a few people put up their hands to ask a question, doing that before we move on to the next activity and the panel finishes. Were you wanting to ask a question? There you go.
Hello, I'm just going to back up Liz Wilkes and Sue with the Mango trial and caseload midwifery. So in response to all the managers and midwives who are worried about the fatigue of being on call for caseload, remember communication. The care provider develops a relationship with the woman and both parties know what the service being offered is and also time management. If you have a woman that's a primip, obviously the antenatal care's got to include a lot of just the regular everyday questions that people are going to be worried about. So you actually do that care, and your expertise will allow a lot of those, I suppose, questions or whatever. So you actually kind of solve the problems before they arrive.
Okay, terrific, thank you. Anybody else with some burning questions for the panel? Coming. Can you say who you are?
Dan Manahan from Stanthorpe. Liz, this one's for you. I'm really interested in the private practice models that I've heard about from you this morning, and it's a specific question about indemnity, and I just wondered, in general, I don't need to talk about your own personal terms, but in general, does Queensland Health indemnify the private practice aspects of eligible midwives in private practice in Queensland Health facilities, or do midwives need to get their own indemnity?
So at the moment we have our own indemnity which covers us for the care of women when they're admitted into Queensland Health as our clients. So our professional indemnity cover covers everything, including intrapartum care in hospital. It doesn't cover intrapartum care at home, but it covers intrapartum care in Queensland Health facilities.
Is that government funded?
No. It's funded by us. So, I mean, we pay for our own insurance. There is a Commonwealth government support scheme that tops up the insurer for if there is a claim that's over from 2 million to 10 million, there's a Commonwealth subsidy, and over 10 million, the Commonwealth, top it. So it's pretty similar, I think, to the subsidies that are available to obstetric, that are built into obstetric insurance for private practice obstetricians.
But the current federal government's about to cut.
And we'll probably face the same issues.
Anybody else?
I'm Bronwyn Buckley. I'm interested in superannuation for the independently practicing midwives. Currently, Queensland Health are a huge provider of superannuation. If you want to encourage midwives into this new model, what are you doing about superannuation? You talk about work-life balance and, the work. How are you going to fund, your superannuation for your retirement?
Our private practice contributes to our superannuation. So we work in a private practice. We're paid by the private practice. The private practice is funded by the care of women. I'm assuming it's similar to the way that GPs would fund their super. So it's exactly the same model as... our private practice model really is, from what I can see from talking with GPs, extremely similar to GP sort of in a business structure kind of way, very similar to a GP business structure type of model. Does that answer your question?
Okay, could you please thank our panel?